Welcome to Discover Health, a White Mountain perspective. I'm your host, Dr. Tom Barela. And today we have an interesting program, a topic that probably many of you come across at various times during your life, but those people that are affected by it are either undiagnosed or refuse treatment. And to discuss this topic, we have a special guest today, Dr. Cara Quade, who has multiple titles. She is a PhD, a nurse practitioner in clinical psychiatry, associate medical director at Change Point up here in the White Mountains, and she probably has a couple other titles I really don't know about, and I'm going to say welcome to you today, Cara.
Well, thank you for having me.
I appreciate that, and I appreciate you coming in today because this show is being taped at the beginning of the holiday season, and so the topic we're going to talk about in a few minutes is depression. But what I think is important is that most people up here probably do not recognize the scope of mental health services that are available up here. So could you start out a little bit and talk about Change Point and the services it provides and you provide?
I'd be happy to do that. So Change Point is actually an integrated healthcare organization. So we provide not only medical care, but psychiatric care as well. We have 4 outpatient sites currently. So we're in Snowflake, Holbrook, Winslow, and then of course in Show Low. And then we also have a 16-bed hospital in Lakeside, known as Change Point Psychiatric Hospital. So we do a variety of services, not only to care for someone's psychiatric needs, but for the integrated need for physical health. And then we also provide group homes or help with housing. We're also looking at additional growth now with a CSU, or a crisis stabilization unit. It looks very much like a psychiatric emergency room, and we hope to coordinate with not only Summit, the community, but also the police force so that we can help to divert people from the emergency room to a more appropriate psychiatric emergency care facility.
So we're going to actually have a pseudo, or probably an actual crisis center up here.
Yep, and we just opened. It's considered a soft opening, so it's part-time, 12 hours a day. But our hope is in the month of December to go to 24 hours a day, 7 days a week.
And is this access telephone number published around here?
Absolutely, I'd be happy to provide that for you. And we also have a referral sheet so we can help the community determine if we're going to be doing outpatient detox versus the need for an inpatient detox from either opiates or alcohol. We look at scoring tools to help people identify if a patient is appropriate to come into the crisis stabilization unit for detox, or if maybe they do need a higher level of care such as the emergency room or hospitalization.
Wow, a myriad of services, and I would be surprised if most of the people that are watching today would recognize this. And that means that you have psychiatrists?
We do. We have a very full medical staff, so we have 3 psychiatrists on now, including Dr. Kent Worthen, who's our medical director, and he's running the inpatient unit and covering all the inpatient beds as the attending. We also have a number of nurse practitioners and PAs, providing services alongside the clinical team. We really like to look at it as an interdisciplinary approach when providing care. It very much is a combination of things. You know, not only do we like to assure that people are getting therapy, their social needs met, but also potential pharmacologic needs met as well if that's part of their treatment.
Okay, so I have 2 additional questions. First, does your center and services cover adults only, or do they include children?
That's a wonderful question. So we actually see people of all ages, and that's one of the loves I have for working in this community. And I have a child and adult practice myself, and so we can see people throughout the course of their lifetime. Many times illnesses begin when we're young, especially the more we know about adverse childhood events. Some of these events that occur, including trauma, changes in our housing, potentially having difficulty with bullying, those things can start the process of emotional disease very early and need to be intervened in very kind of aggressive and assertive ways to assure that the person grows and is able to maintain those symptoms as they become an adult.
Okay, so a full scope of services for children and adults. So the second question that would come out is also an easy question for you. Community counseling services, which I think was your predecessor,
Right.
Mostly was involved with Medicaid and type services, and does your current ChangePoint include commercial patients?
Absolutely. That's a wonderful question. I think we're largely known for managing access and Medicaid,
Right.
and that still is the largest portion of our care. However, we do take private insurance, private pay, as well as Medicare.
So a full scope
Full
of age,
scope.
full scope of insurance. And it seems to me that its ChangePoint is growing, because it didn't seem like we had 3 psychiatrists up here for a
No.
long period of time.
Right. We're growing incredibly, and the opportunities are limitless. I think that that's the biggest challenge that we face today. We're having a strategic planning meeting to talk about meeting the needs of the future and really being innovative in doing so, because psychiatry or mental health is so absolutely important. I think for a number of years, there's been a bit of a stigma, and we've focused with mental health kind of behind closed doors, things people felt that they needed to handle on their own. So now we're moving forward, seeing that there truly is a science, and it's so incredibly prevalent, and we really, as a nation, need to target those concerns and try to work on the whole health of an individual, not just medical treatment. You know, the head and the body are certainly all attached.
And we're going to talk about that when we talk a little bit about depression. And we have other mental health providers in the community, psychologists mostly, PhD psychologists. And one of the differences between the psychologist approach and the approaches that you're able to do is the prescription of drugs. Is that medications? I'm sorry.
Yes, no, that's absolutely true. So psychology in general is the scope of being able to do therapies and other endeavors that are natural and don't require pharmacologic intervention. And so I think we're very lucky to have a community full of providers. But where we separate ourselves is that we are able to target the potential treatment in ways that include pharmacologic use, so that may be medication, but we also still utilize a number of natural techniques. You know, I commonly suggest light therapy, especially now that we're looking at coming towards the holidays, and we know that seasonal effect of depression is pretty significant. So we look at it more as maybe a multifaceted approach to treatment of depression or any other mental health disorder.
For me as a practitioner, I think it's important that our audience recognizes that mental health services are in an incredible shortage, not only in the urban centers of the United States, but even more so in rural communities. And to recognize that ChangePoint has provided a functional basis for all of these services is really amazing for our community. And I hope the audience would recognize what a significant event this is.
Literature would support that incredibly. In areas where there is a lessened number of psychiatric providers, there is an indirect correlation with the number of suicides. And so we want to increase our number of providers in any way possible. So we utilize telemedicine services, and we've also partnered with Summit to try to bring about integrated approach to psychiatry in their urban centers and rural centers. And so hopefully we'll be able to continue to spread out the availability of providers even to the Heber area and beyond. So
wow. This is exciting for me.
it is exciting.
It is very much exciting
growth.
because I know how we have struggled even in the big cities for adequate provision of services, especially, at least in my case, for children. So let's go on and talk about depression.
Okay.
Depression is something that I think most people are aware of, certainly as a topic of conversation, but I don't think a lot of people recognize how significant of a problem depression really is.
Absolutely. I know we were talking about the National Institute of Mental Health statistics that 1 in 5 Americans has been diagnosed or has symptoms of a mental health disorder within their entire lifespan. So that's considerable to think that 1 in 5 of us is really struggling, and oftentimes we do that alone. I commonly complain to my patients that it's a difficult thing because it's an invisible illness. It's on this molecular level that people are experiencing, whether it be a chemical change or something that they're going through. And so they often feel that it's a weakness because it's not something they can see, like a broken arm. If you had a broken arm, everyone would run to you and try to provide support, and they would know exactly what
Sympathy.
to do. Yes, oh, absolutely. So when you feel that maybe it's a weakness or something that you have a character flaw, people generally fight all alone and really don't know how to express the symptoms that they are experiencing. So I'm hopeful today that we can shed some light on depression and help people to see that there is the chance to get help and to improve life.
And there are lots of associations. I mean, 20%. And that changes with age too, doesn't it?
Right, so let's refer to this slide and go through some of the larger statistics. So major depression affects 15 million people every year. 6 million elderly are affected by depression. 25 to 75% of people with a major life illness are also depressed. Major cause of disability worldwide. And we see a greater likelihood of this occurring in women versus men, almost 2 to 1. And the highest rate is generally in the age group of 40 to 60. And it's the cause of 70% of suicides. And of course, we have to be really cautious and be aware with our teens. It's untreated depression is the #1 risk for teen suicides, and that's a growing number.
And it's scary because I know that at least in the pediatric and teen statistics, that the depression associated with bullying has also been a significant issue for recognition.
Oh, right.
Because the kids kind of regress and stop going to school. So
It's horrible.
It's horrible. Now, I want you to take a second here and describe what major depression is.
All right, so if we were to look at the symptoms of depression, major depression is something that is really classified by the DSM-5. We look at a statistical manual, and it is a number of criteria that need to be met. It's generally an episode that lasts over a 2-week period of time. And when we look at the symptoms, just for thoroughness, we'll go through feelings of being sad or having an empty mood, feelings of hopelessness or negativity, being pessimistic, irritability, feelings of guilt, maybe even worthlessness in one's life, anhedonia, which the lack of pleasure, things you normally love to do, you really don't feel like doing them anymore. When you do them, there doesn't have that natural, pleasureful response that you would have normally had. Low energy, a lot of fatigue, also maybe moving around slowly. We call it psychomotor retardation, but it's not really the ability to express yourself well, to think things through well. Difficulty concentrating is another big piece. We also see sleep changes. So someone may very well not be able to fall asleep or stay asleep, or the opposite end of the spectrum. They may be sleeping far more hours than they ever did in the past. And then thoughts of suicide are very common, and it's an incredible red flag in depression treatment, and being aware of what those are and being able to talk with someone about the severity of those things. And then one thing people don't commonly know is that depression, through a process of inflammation, can affect one's medical status. So there are generally more aches and pains, headaches, gastrointestinal upset, and so it's very important to kind of track all of these things and work with a provider to be very aware of the entire spectrum of the illness.
And I think what you described is termed psychosomatic, the psychological, somatic meaning an expression of illness. So, but it can work both ways.
Oh, absolutely.
The somatic problems cause depression, as we'll talk about in some of the risk factors and stuff like that. A very good point. Now, the next question would be, children are a little bit different in depression, and I don't think most pediatricians and physicians are good at picking up the symptoms of depression in young children.
Right, and so I think it's really interesting to note that children often show a little bit more irritability and anger, and they have feelings of sadness, but they tend to withdraw, and so they may spend more time in their room, they may spend time away from their friends, or have less desire to be out in public or to go to a birthday party. They also are more sensitive to rejection. And I know in my own mothering, that's a difficult thing because there are periods of time where they go through sensitivities or their friend said something that hurt their feelings. So it can be difficult to separate, those two things, whether it be just a response to the environment or what they're experiencing versus that of depression. You're going to see some of the same factors, though, that you would see in adults. We would still see changes in appetite, potentially, up or down. Changes in sleep, same, up or down. And then difficulty concentrating and maybe more outbursts. So you may have a child that's a little bit more oppositional than they used to be, more difficult to work with, a little bit more frustrating for mom or dad.
Nah, it never happens.
No, and physical complaints are yet another thing. So one of the most classic, even in childhood anxiety, is that there is this constant complaint of stomach ache, constant headaches, the desire to stop going to school or saying, I don't want to go today. And so if you've been to your medical provider, your pediatrician, and they've said, we just can't really find anything particularly wrong, that might kind of cue you in that there's another etiology or another reason behind why the child is feeling that way.
Yeah, chronic abdominal pain is a big problem in childhood and is a manifestation in most cases of some kind of a psychological effect on them where they get that empty pit in the stomach. Unfortunately, it frequently stimulates a lot of medical workup because you're always worried about the serious medical
and a lot
stuff.
of anxiety then.
So are there any risk factors for depression? I think those are on the next slide.
All right, so we have some really evident risk factors. One is personal or family history of depression. So if maybe your grandmother or your great-grandmother had a severe depressive episode, maybe your sister has had symptoms of such a thing, that's the number one risk factor that we're able to identify. Other things we know are major life changes, trauma or stress, and this includes adverse childhood events. That's a very high indicator of later life depression. And then certain physical illnesses. I think that was wonderful that you brought up. What came first, the chicken or the egg?
Right.
But what we know is there is this inflammatory process that occurs, and people who have either bipolar or depression diagnoses are far more likely than the general population to be diagnosed with cardiovascular disease or metabolic concerns such as diabetes. So we have this correlative spectrum of illnesses, and it's really important that now we don't try to separate the two, that it really is that if we are able to impact depression in a positive way, we are able to impact one's physical health in a positive way. So we need to be very, very well aware. I think the one thing that this slide is potentially missing is that substance of abuse, too, is a huge risk factor. So oftentimes, people who are abusing alcohol or methamphetamine are at far greater risk to suffer depression symptoms as well.
I think it's very important to people recognize exactly what you're saying, that there is things that can be done with recognition. And I know we're going to talk about that towards the end of your presentation today, but I just want people to understand that there are things that can be done.
Absolutely.
And so I just would like you to spend a couple seconds. I know depression is a very, very broad spectrum. There are different triggers and stuff like that. And so, major depressive disorder is a very debilitating condition.
Incredibly so. It's one of the leading causes of disability worldwide. And so we know that not only does it affect the person, it affects their ability to be part of a family, potentially to be a parent, to maintain employment. There's a huge socioeconomic impact of depression, and I think of it kind of like a rippling out effect. And it's difficult because you don't have a lot of support, kind of going back to the idea of it being an invisible illness. If other people haven't experienced depression or they don't know of it as being a true disease process, they may feel like, you just need to pull your bootstraps up and get to work and do what you need to do. So I think in that it makes it a much more complicated illness because you feel so very alone, and there aren't ways to really move forward until you get, hope through treatment and working with a practitioner who might bring about ways to become well.
I like that term, hope through treatment.
Absolutely.
That's a good way to look at that. So, there are some depressions that really occur that people do in fact get over, and a
Absolutely.
big one that is now in the news is postpartum depression. The American Academy of Pediatrics has recommended that all pediatricians screen mothers for postpartum depression at their 2-week child visit and again at 2 months of age, and with a formal questionnaire.
That's extraordinary. So during my doctoral work, one of the focuses was utilizing psychiatric questionnaires in practice to help build kind of a quantitative approach so that you can measure someone's symptoms and that you can gather the information that you need to be able to correctly diagnose. But in that research, I found that postpartum depression was just as likely to occur as gestational diabetes. And so it was
Really?
brilliant to me, because I thought, here we are routinely looking at women for diabetes during pregnancy.
Right.
Why would we not also be doing the same for depression? So it's lovely to see the world catch up, the clinical practice, start reflecting what we need to really be able to thoroughly treat each individual.
I like that.
That's good.
I did not realize
Yeah,
that
it's
the
4%. It's
same
outrageous.
frequency.
Yeah.
Wow. Talk a little bit about situational depression, because most of us at one time of our life get situational depression.
Absolutely. So situational depression can also kind of be referred to as an adjustment disorder. This is that something very traumatic will occur in our lives, or we'll go through a big life change. Oftentimes it can be young men going on a mission, maybe someone getting married, the loss of a loved one even potentially. We have this period of time where we experience depression symptoms, but then over maybe 3 months we start to see an improvement and we can recover. There's a better recoverability on our own, with our own sleep patterns, our nutrition, maybe exercise, that we are able to get back to feeling ourselves. And that's one of my favorite statements from patients is, I feel like me again. And so that would really be the key term. I think the goal is to get back to being yourself once again.
Perfect.
Yeah, but then there's different, we also have seasonal depression, and seasonal is more where we refer to it as SAD, where the season changes, most particularly winter. We have shorter days, so people tend to experience more depression symptoms just moving into the winter season. But then as the days get longer, the sun is more prevalent, those things tend to resolve as well.
And I know we have bipolar disorder on here, but and you mentioned it a little bit earlier, but it's really a complicated topic. And I want to spend some time, as our time is almost over, talking about treatment, because I think it's very, very important that people understand that you can recognize this and treatment helps. So can you talk a little bit about depression, not even the far spectrums of severe depression, but how you could go about treating depression when somebody comes to see you?
All right, so generally I like to explain this as a disease process first, because I think a lot of people are under maybe the stigma or the understanding that this is a weakness, that psychiatry really isn't a science. And so I try to explain that if someone had diabetes, you wouldn't expect them to go without their medication. If you have depression, I wouldn't expect you to go without these multifaceted ways by which to treat your depression, including medication particularly. And then I also like to look at each person like the hub of a wheel. So if we were to think about all of those spokes, we need to evaluate each one of those and then start developing a plan that targets each one of those spokes. So I don't like to start with medications, but usually by the time they get to me, they've been seeing a therapist, they've been seeing their primary doctor, they've maybe, started doing things that are natural in its approach. So I'll secure that. We'll talk about things that might improve. We know sleep and sweat. So that's just number one priority. You must be sleeping well. You must exercise daily. And when you're feeling depressed, you don't want to really exercise. So we have to get to that place, maybe forcing ourselves to get up, take a walk. Research shows as simple as 7 or 12 minutes can improve mood for up to 10 hours. So it's really astounding. So the natural stuff is good. Maybe supplements. Maybe you have a vitamin D3 deficiency. Maybe you have hypothyroidism. So we also look at potential medical conditions that can complicate depression symptoms. And then we talk about medications as well as therapy endeavors to help potentially treat the symptoms that are holding the person back from being well. What we know, just like any other medical condition, is the longer you wait to treat, the worse the symptoms progress, the more difficult it will be to treat and get back to baseline. And so I tend to not want to waste a lot of time because most people have been miserable for quite a while before they finally get to my office. So we talk about things in a bit of an assertive way too, that we have a step-by-step process, but we need to continue until someone's very well.
You know, I like your description of it as a disease entity, because if people had a cold, they'd try to get well, and if they didn't get well quickly, they would see the doctor.
Exactly.
And you know, the intervention is the key to this, and I think the psychological undertone of having to see a psychologist or a psychiatrist for a mental problem makes people uncomfortable. And the point I want people to understand today is that you don't have to feel that way.
Right.
If you view it as an illness, you get the treatment, you get better from the illness.
Absolutely. And you have better quality of life all the way around. And I think that's the beauty of integrated care. As we've progressed in that direction, I think that that is potentially the future for all medicine, that when you are in to see your medical provider, you may see psychiatry at the same time, because all of these things are so linked and the science is so extraordinary. If you're able to see brain imaging and you're able to see the response to treatments on that level, I think it really provides someone with something that's tangible, where in psychiatry we haven't had that for very many years. So it's a really neat progress to see, and hopefully reducing the stigma, allowing someone to see their health, including their whole health, is really the goal.
And many people who have depression essentially see their family doctor or their internist and stuff like that, and receive a medication approach. And many times that does in fact work for most of the short-term, situational, seasonal, whatever type of things. But there are times when the second level is necessary, where you need some type of a counseling intervention, which is part of your integrative approach at Change Point.
Absolutely, and research supports that as well, that people started on an antidepressant alone by primary care. 30% of people will go into remission from symptoms, which is lovely. 30% is great when we talk about just one small endeavor. But the truth is that means 70% of people still struggle with symptoms of depression despite that treatment. And so oftentimes we need to look at something that may be a little bit more complex in a more integrated format. And so I would just appreciate people to understand that they need to maybe consider becoming fully well, not being okay with just a little well.
I like the concept of fully well. And Cara, I got to tell you, we're out of time. It goes quickly.
It sure does.
When such an interesting topic is there. And I'm going to finish by saying to our audience that this is a very interesting presentation by Cara, because we have not had such extensive services up here on the mountain. You recognize that if you are having problems and the medication may not solve them, you now have a resource for both inpatient and outpatient. And I thank you and hope that this has been instructive. And thank you very much for watching, and we'll see you next time.